and welcome to the Department of Medicine Grand Rounds. The CME code for this morning is 25170. For our last and final Grand Rounds of this academic year, I'm sure we're all going to miss Grand Rounds for the next couple of months until after Labor Day. I am happy to introduce our speaker. Dr. David Doukas is a professor emeritus of family and community medicine at Tulane University School of Medicine. He's also the former James A. Knight Professor of Humanities and Ethics in Medicine. He's a nationally recognized leader in medical ethics, professionalism, and the humanities, and he's held prominent roles at Georgetown, Michigan, Penn, Louisville, and now at Tulane. Dr. Doukas is a certified healthcare ethics consultant and past president of the Academy for Professionalism in Healthcare. He's directed numerous programs in ethics and professionalism education and is widely known for linking classical virtue and care ethics to clinical teaching. He's received multiple national honors, including presidential citations from the American Society for Bioethics and Humanities and faculty recognition awards in professionalism. A frequent national speaker, Dr. Doukas has given close to 100 invited lectures, including recent Grand Rounds and our current Grand Rounds today on professionalism and humanism in medicine. Thank you, Dr. Doukas.
Thank you so much. So let's see, how do we go back to the sharing screen that we had? We seem to have lost. There we go.
We found it.
Yep. Bumped it back up to the front. All right, so thank you so much for allowing me to share your morning, and I want to thank Dr. Cohen for the very kind introduction. I'm going to be talking about the rightful place of humanities in the context of professionalism in the clinical and learning environment. And so what I wanted to, we're not advancing. There we go. So no conflicts of interest. And then I wanted to go ahead and talk about how professionalism is currently evaluating professionalism, and that there are specific things that are missing. One having to do with positive reports of aspirational behavior, and then requisite education in ethics and humanities for professionalism to take hold and be sustained. And also talk about how to improve professionalism programs. So I'm going to let me eliminate this. So case concerns, this is taken from a real case, anonymized, and it has to do with a surgeon who was having inappropriate behavior in the OR. And it had to do with production pressure. And this surgeon would consistently rush his teams into the OR, physically touch residents and OR to hurry them, made demands regarding turnover that would and could compromise patient and employee safety. Well, it culminated in a circulating nurse hurrying to provide equipment to this surgeon. The nurse slipped, fell, and had to seek treatment at the emergency department. And the incident highlighted the ongoing issue that this surgeon's behavior had caused with consequences for both staff and patient safety. This was the 5th reported professionalism concern about this surgeon in 3 years. And at the 4th juncture, it was referred to the dean. So what I'm going to be talking to you about is a little bit different than what you typically talk about in a medical ethics class, which normally we talk a lot about deontological ethics that is divined from the duties that we owe to each other. We're going to be talking instead about character, i.e. virtue ethics. And so while other ethical theories are very important in moral decision making. Virtue theory is concerned about the process of becoming the moral person you aspire to be. And when you become a moral person, you'll do the right thing. So it defines the qualities that make a person good. It is non-normative. There are no strict laws to follow. Instead, it identifies the character to have and assumes that the person with that character will be acting appropriately. So from Aristotle, excellence is an art won by training and habituation. We do not act rightly because we have virtue or excellence, but rather have those because we have acted rightly. We are what we repeatedly do. Excellence then is not an act, but a habit. So what is professionalism? Professionalism is a promise to do something for someone with limits. I break it down into four pieces like that to make it easily digestible. So, medical professionalism is an oath-based promise by the physician, grounded upon competency, that is, the knowledge and skills that are taught to you, to promote patient benefit while rejecting self-interest and to maintain a covenant of trust with society. So the first part that we look at having to do with competency, we are professing to society that we have a certain set of skills and requisite knowledge in science, but also in the humanities, the arts, and comportment and critical thinking skills. And then we take this knowledge and we then use it to promote the patient's best interests. And very importantly, that the patient's interests are greater than self-interest. Now, there is this implicit contract between the healing arts and society that goes back literally millennia, founded upon this duty of care, respect for autonomy, competence, accessibility, and equitable care, ethical conduct, collaboration, communication, and continuous improvement. And very importantly, medicine as a profession monitors itself. So we do not have some form of external body, police or others, that are then saying, okay, you're going to go ahead and get in trouble if you don't do this. Instead, we monitor ourselves. I wanted to go ahead and reflect for a second then on Epidaurus. I visited there with my wife this past year at about this time. And this area developed from the cult of Apollo Meletus during the 6th century BC. This is way before Hippocrates, and was the official cult of the city-state of Epidaurus. And the principal monument was the Temple of Asclepius, but there was also the Tholos and the theater. People would bring their medical problems to this healing center. They would make donations, and also there would be sculptures and prayer offered in order for the resolution of a variety of things. So uh, we saw sculptures of somebody's ear, for instance, to bring back their hearing, that sort of thing, dating back from the 4th century BC. It's a huge site. It's still being uncovered, and it has temples, it has hospital buildings, an immense dormitory building, and then very importantly, it also had a huge amphitheater where plays would be enacted and acts of catharsis would then be encouraged from the patients in living out the problems that they were having. So this is Epidaurus. So when you think of medicine, you don't think of things like this, but this is where it started. So professionalism is all about the patient. It isn't about us. It isn't about our gains. It isn't about the things we aspire to economically. It's about the betterment of the patient. And our training and all the things we do are to help the patient's needs, and that the patient's health and survival is going to depend on the physician. So again, to restate, this is what medical professionalism is. That means that there's going to be an attendant medical education goal, and that is to teach our learners how to integrate their role of being a scientist with the application of medical ethics and humanities to better promote the patient's welfare. I say this on point because Abraham Flexner's report to the Carnegie Foundation in 1910 is often misconstrued as Flexner rejecting humanities, instead concentrating solely on science. What Flexner was trying to do was institute a new curriculum basis upon which medical scientific training would take up the bulk of the first 2 years of medical school, followed by 2 years of clinical practice, and then some form of apprenticeship, later developing into what we now call residency. Um, I, along with Doctors McCullough and Weir, went through an archival search of all the teachings and writings of Abraham Flexner, and he actually wrote all about everything from the collegiate, but also high school curriculum. And he emphasized how important the humanities were in terms of the development of the physician. His expectation was somebody was a well-heeled student in the humanities, meaning having background in art, ethics, history, and literature in order to bring it to bear to medical education. And this then established the foundation for the PRIME, or Project to Rebalance and Integrate Medical Education. And there we have many, many publications in academic medicine and elsewhere as a result of this project. So our thesis was that we need to use a Flexner-inspired framework to use ethical argument and analysis to teach our learners reflective narrative and utilize it for their own development, to have fundamentals of observational skills in the fine arts, and history regarding the art of medicine. It also meant that we wanted to encourage sound mentorship opportunities and role modeling in the apprenticeship to cultivate humanistic attitudes, behaviors, and interpersonal skills. Well, there's a problem with all this, and that is while we try to do ethics, humanities, and uh, role modeling, students and practitioners sometimes seem to have a failure to execute successfully in the clinical circumstance. So these are true quotes, anonymized, that these were all complaints about learners and faculty, and so, such as somebody ranted about their superior, somebody left their workstation, couldn't be found for hours, so and so berated a medical student in front of others, somebody cursed at a resident, somebody else was cruel and abusive to fellow students, somebody else was condescending to the residents, somebody was bullying and hostile, and on and on and on. So healthcare institutions have attempted to respond to implementing some kind of a professionalism program. Now, there are two different types. The first is a peer review process that is run through the chief of staff or dean's level offices, or some form of a critical response entity that addresses primarily negative conduct. Now, we started at Tulane 7 years ago having a professionalism program called the Trio, and it was based on having three elder statesmen and stateswomen who would respond and triage ethical issues using the Vanderbilt professionalism. I'm sorry, I've got some noise outside my window right now. Um, we use the Vanderbilt professionalism response program by Gerald Hickman to engage with people when there are lapses in professionalism. And then if there are repeated offenses, you would again engage them. If there are heinous or more than three offenses, then it would be referred up to the chair or to the dean, depending on how bad it was. And anybody, including the dean, can have a professionalism complaint or concern put forward. I joined the trio with one caveat. I said I have two conditions for my joining. One, we need to have a way to respond to people who are doing well. And that gave birth to what we called the kudos system. So when somebody did a great job of something, really role modeling excellence and professionalism, they would receive a kudo, and that would be a lengthy communication directly from the dean saying, we want to thank you in this circumstance when you did this, and how that role modeling helps the institution broadly at Tulane. The other issue was to institute some form of a longitudinal curriculum to promote medical professionalism through ethics in humanities education. So we can't just focus on negative outliers, because if we were to do that, and if we have done badly in not A, picking the right people, but also B, not teaching them, who's failing here? Is it the person when they have this professional shortcoming coming out, or is it all of us? Is it a system failure? It's sort of like when you do systems level analysis post airplane crash. Are you going to blame the one person who didn't tighten a wrench enough on a bolt and that caused a catastrophic failure? Or do you look at the entire process of putting the plane together and that process had failed in addition to the person who was the point source? So if we only look at the negative role exhibitors and ignore the positive role models, we're otherwise really demeaning those people into whipping boy status. Educational backgrounds and levels of character and maturity for learners as well as teachers vary. You know this from the people around you at the Grand Rounds. We also have some institutions that have excellent professionalism education with sound curricula. And the problem is these programs are few and far between. They're not the rule, and they're not something required by LCME or ACGME. So we can't really be surprised by professionalism outliers, the negative outliers, if they experience a dearth of this requisite education and role modeling. So this is your statement on professionalism in the workplace. It's a very long narrative. I'm not going to go through this. Suffice it to say, it's intended to promote professionalism and to also look at circumstances where policy is being violated and norms are being violated. Some of the examples on the lower half of this are here are some of the positive: to behave courteously and professionally, to follow Rutgers policies, to be honest uh, and have ethical research endeavors, to provide thoughtful, ethical, and kind clinical care for patients, to participate in open professional intellectual discourse, and to avoid language that could be considered demeaning or aggressive. So if you notice, most of those bullets are positive, which is a good thing. Here is also the requirements for promotion and graduation for the medical school. And again, you have all these bullets that look at here are the things that we're expecting in a positive way, but they also note aberrant behavior or general or specific conduct meriting concern as being negatives that would need to be responded to. Well, Rutgers has a way of doing something about that. So in terms of assessment for professionalism, faculty can identify students who've exhibited unprofessional behavior. And so faculty or the dean can then, one, file a professionalism conduct form, two, issue an unprofessional behavior warning to the student, and three, write to the dean to request disciplinary action against the student for a violation. Now, I am noting one thing. Now, these were the things that were sent to me by Dr. Cohen. So I don't know if there's a similar way to identify students who say, we feel a faculty member is exhibiting unprofessional behavior. I would hope that there is some way of having reciprocity in this relationship. You may be asking, however, where is this professionalism conduct form you're talking about? Well, here it is. So you see several of these bullets under professional responsibility, several under self-improvement and adaptability, honesty and integrity, and then relationships. So again, rooting back into virtue ethics, we're not talking about autonomy, beneficence, and justice. We're talking about what is the core character of the student here. So are they not being punctual and attending to the needs of the learning environment? Are they not being forthright when mistakes occur? Are they arrogant? Are they defensive? Have they falsified data? Do they deceive others? Are they abusive? Do they not respect the wishes of patients? So we have lots of ways in which, if you are a teacher at any level, you can file a professionalism conduct form for regarding a student. Um, I would actually go so far as to say it works both ways, because there may be faculty who may do the same things. We may be expecting more of them, but frankly, when I retired from the trio 2 years ago, but we used to see plentiful violations by faculty as well. So what I want to do is focus on moving beyond punishment, on the ruler on the hand. And so what we need to do is reorder what our requirement is for ourselves in promoting professionalism. Because the whole notion of prevention of lapses is flawed if the aspirational nature of professionalism is not set as the North Star, the primary goal of education. So yes, we do need to react to negative outliers, and I'm sure we can talk about that in the discussion time. But also we need to responsively and publicly proclaim and acclaim positive outliers. And with permission of when somebody is cited with a kudo, we post on the web page all the kudos for the previous semester. And we will even include the language of why. So, for instance, in the wake of Hurricane Ida, that was now 3.5 years ago, coming up on 4 years, we had many, I would say, kudos because we had people doing double shifts or in the height of the storm, they were taking personal risks to go ahead and help other healthcare providers get to the hospital, a variety of things that were proclaimed as morally laudatory. And then we also proactively, with a longitudinal curriculum, need to promote professionalism through ethics and humanities and to promote mentorship and role modeling. Now, reactively, this is something from AAMC. We have a variety of things where mistreatments and breaches of professionalism are being responded to. That's step one. That's the easy part. But AAMC had promoted then, since that time, core and trustable professional activities for entering residency. In other words, it is the expectation that these 13 core EPAs be attained prior to entry into residency. Now, let's start from something that is a truism. We are all imperfect. I'm imperfect. You all are imperfect. We all can very, very likely improve. We can aspire to have the highest character that will result in the excellent health and medical benefit of our patients. And we can all seek peers and mentors that can promote our moral growth. For some, though, they want to just say, well, why don't we just get great students or great residents when we're doing recruiting? It's not so easy. There's no way of testing that out. And the problem is we need to have a level playing field in each of our learning environments where we not only teach people about autonomy and beneficence and justice, the pillars of deontology, but also virtue and care ethics. Educators have a hard enough time just teaching deontology, however, with very little time being spent on virtue ethics. Professionalism is integral to our development and our practice, and AMC's, academic medical centers, need to nurture professionalism. And it's better for AMCs to track and address the shortcomings of those, as well as build the environment to make a better resident and better faculty member, rather than having later state boards of licensure having evaluations for improper conduct, suspension, and revocation of licensure. So, virtue and character, I just wanted to spend a little bit of time. To be virtuous is to have a virtuous character. That means the habits or dispositions to act in certain ways. They come from action comes from virtuous character, and the virtuous person wants to act virtuously and does so for that reason, not because of fear of penalty or retribution. They do it because it is its own reward. The theory of virtue ethics originated in ancient Greece. Virtue, or the Greek term of arete, meaning excellence, is summed up nicely by Socrates. It is the greatest good for a man to discuss virtue all day on the grounds that the unexamined life is not worth living. So, virtue is supposed to be a kind of knowledge identified with wisdom, or again, the Greek word sophia. And wisdom is both necessary and sufficient for virtue. The analogy is that a skilled athlete or a musician physically changes his or her body through repetitious actions. And in the same way, the virtuous person finds it easier to act virtuously. She literally changes her physical and emotional characteristics. And that's done by repetition. You keep doing the right thing. These are the clinical virtues of note from the Virtues in Medical Practice from my mentor, Edmund Pellegrino, and his colleague, David Thomasma at the time, of compassion, fidelity to trust, fortitude or courage, integrity, justice, phronesis, also called practical wisdom, self-effacement, meaning shunning self-interest for the betterment of another, and temperance. So these good habits, they're formed at youth and make all the difference. So everyone has a different background, and we need to try to nurture, but also plant seeds for growth intellectually and morally at every stage of medical education. So Pellegrino and Thomasma asserted they need to incorporate virtue ethics into medical education. And that did not mean you're going to read a bunch of books. They said it really comes down to having sound role modeling and apprentice-like interactions, and also to mesh that with the principle-based ethics that is currently being taught in clinical ethics. But the dark matter I allude to in the title of the slide has to do with Fred Hafferty's observations regarding the hidden curriculum. We can teach all day long medical students and residents, but if they go onto the clinical wards and then they're untaught that, oh, you don't really need to do it this way, you can do it that way. Back in the old days of paper prescriptions, medical students would come from their first 2 years of medical school, they'd hit the clinical wards, and we'd have residents saying, because I remember this happening way back in the early 1980s, here, sign all these prescriptions for this patient who's about to be discharged. I'd be, no, I can't do that. I'm not a physician. I'm not allowed to do that. And so the hidden curriculum unteaches not only principle, but very pointedly virtue-based educational efforts that can and should be going on. And so what that means is you need to learn where the hidden curriculum kinks in the armor of medical education occur, and then remediate and undo them. So, how's virtue relevant to what we call today's physician? Well, the ACGME, the Accreditation Council for Graduate Medical Education, has this set of general competencies. Uh, Originally put forward in the late 90s, but officially made part of guidelines back in 2002 for all residencies, that there are 6 different general competencies, but there was one specific ethics-based competency called professionalism that was seen by Tom Naska, who promoted this entire superstructure as the keystone of all 6 competencies. And the other thing that's really important, that if you read all 6 competencies, you will see that professionalism and ethics is embedded in all 6 of them. It's just that there is a whole lot of target-rich literature within the professionalism competency. And there are parallels in LCME for medical school, AACME for CME education, and for Joint Commission requirements. So I directed a scoping review project to evaluate how virtue and care ethics education contribute to humanism and professionalism. And we did this thematic construct on enhancing professionalism evaluation and then sought to find out what are the themes that help and hinder professionalism education. We were looking for three basic things in the articles that we reviewed. Normative argument for virtue or care ethics, curriculum that evaluated and improved humanism, and a linkage to humanism and clinical practice. So this is sort of just a little diagram. We first went through PubMed, then through an additional four sub um, databases that are outside of PubMed, and we found a total of 766 papers. We then filtered it by the normative construct, the curricular utility, and linkage to humanism. And we wound up with an astounding low 25 papers. And we then looked at themes, metaphors, and concepts to construct a line of argument synthesis. So I'm going to blow through this slide because what it does is it lists all the different papers, but these are the types of themes that came forward and then side issues that were cited. So this gives you a more realistic way of how development occurs, that we have a set of papers that promoted virtue development, another on altruism, and another on care as a virtue. But there was these impediments of virtue principalism dissonance. In other words, if we're teaching autonomy, beneficence, and justice a whole lot, but not a whole lot about character, that medical students and residents don't really know exactly how to blend or mesh these together. And then in the clinical realm, we have pedagogy in terms of how do you teach the stuff, and role modeling with a resultant practice, or the Greek word praxis, of humanistic behavior. And there, the impediment was the culture itself of the hidden curriculum. And then the noteworthy considerations having to do with narrative, burnouts prevention, learning communities to promote it, and resultant professionalism. So it's not just about rules. The question of what is right or obligatory to do is not the only question. We have to also consider the character of the agent and how do we address the gaps. How should we be matters, because it is only by becoming a better person that will do the right thing. So let's go back to our case. Remember our surgeon rushing everybody and the nurse hurrying to provide the equipment, but then they slip, fall, and had to go to the ED. And this was the fifth concern. So this person had already had several informal meetings, or what is called a cup of coffee, a couple of times. Then on the fourth time, it was sent up to the dean. And now, even after that, we have this circumstance that occurred. So we as a team, the trio, deliberated, how do we respond to this kind of a circumstance? Together, we deemed this a red card violation. that something, think in a soccer game of yellow card, red card. This is you're expelled. So we stated to the dean, this surgeon needs to stop operating now. He's endangering others. That he be suspended from all future surgeries until he meets with the dean, meaning ASAP, and that a performance plan needs to be put in place and adhered to with sanctions laid out by the dean, including termination from the faculty if that reported fails to meet expectations. But let's get back to looking at the positives and looking at the curriculum. Programs need to understand how they should improve their enhancement of professional conduct. So the framework I'm going to lay out in these next few slides has to do with 3 levels of professional formation. The 3 levels are roots, knowledge, and skills based on the themes that you saw before. So with roots, we attempt to identify gaps. So whether it's on an individual person or whether we're thematically analyzing a series of professionalism concerns of multiple people, we need to look at can we teach an integrated ethics and humanities content so that we have knowledge and skills put forward to all learners, not just students, not just residents, but to faculty, students, residents. We need to nurture mentorship and relationships through sound role modeling. And that also means utilizing the ACA-GME and LCME now, competencies and milestones, paying serious attention to the moral development of our learners. And then we need to get the PIF or professionalism, information, learning community, socialization. So we have people gathered together in these learning communities to help socialize and normalize and promote the cultivation of virtue for our learners. For knowledge, we need to identify gaps there. And in that case, we need to make sure that we're really highlighting what the basis of altruism as a medical professional is. What does it mean to teach and then demonstrate ethics of care? And how can and should we develop virtuous traits in ourselves? How do we address the dissonance of virtue versus principle? And how can we teach our learners and our peers how to resist the hidden curriculum? And then how can we and should we teach it according to the resources of our own institution? In terms of skills, we need to identify gaps of relationships. How can we build or nurture relationships between peers and also between mentor apprentices? How can we cultivate sound practice or praxis through the demonstration of humanistic behavior? How can we be kind to others and to relay the fact that we are intending to benefit the patient first at all times? And then how can we encourage role modeling so that we have not a me first stand being taken by teachers, but instead my duty is to teach my students, my learners, my residents and students, so that they learn to be excellent clinicians. On an individual basis, then, how can anyone engage another to improve professionalism in any setting? I would respond by saying, strive to be a good role model of virtue, to praise others who demonstrate excellence in character, and to educate others on the nuances of critical thinking from the domains of ethics and humanities. Benjamin Franklin wrote this many years ago. It's something I usually will communicate with others at the turn of a new year. Be at war with your vices, at peace with your neighbors, and let every new year find you a better person. So, any questions?
Yes, thank you very much, Dr. Doukas, for a wonderful talk. Remind everybody that the CME code is 25170. If you have any questions or comments, please post them in the chat. Dr. Doukas, I wanted to, you briefly mentioned the cup of coffee
Yes.
discussions. So this is something, and my understanding is this started at Vanderbilt, or
Yeah.
the Vanderbilt project. And our school has recently adopted this, and we have a number of faculty in our department who are cup of coffee messengers.
Right. Peer
I don't
messengers.
think
Right.
I think that most of our faculty aren't aware of this format. I don't know if maybe you can describe it a little bit more, and then for those of us faculty who are cup of coffee messengers, you can provide us with some practical tips on how we can discuss professionalism with a colleague.
Sure. So the peer messenger interaction is intended to be a non-judgmental conveyance of a professionalism concern that's been raised. And so what that means is if I were to sit down with somebody where there was a concern, this actually happened, I'm going to say in the late fall, where there was a professionalism concerned. And what we do, by the way, is we have peer messengers based on their rank within the institution. So an assistant professor or instructor will speak to another assistant professor or instructor. An associate professor will speak to an associate professor, and a professor will speak to another professor. And that way, there's not a power differential so that it looks like you're lecturing down to and exerting power upon the person when the professionalism concern is being put forward. Um, the important reason being that we're not intended to be a moral bludgeon against this person. We are intended to be a dispassionate conveyor of the concern, relaying whatever has been communicated to the professionalism program, and to then let that person digest that information, and then we're not there to go ahead and listen to some sort of defensive, I didn't do that, I've never done that. That's not our role. Our role is to say, we just want to communicate what this anonymous person has put forward as a professionalism concern. It's up to you now to take this, internalize it, think upon it, reflect on it, and consider how you can improve yourself as a teacher or as a clinician. And the reasoning for this is if you just shot an email to the person saying, oh, yeah, there's a professionalism concern.
Okay, Google, remind me at 1 o'clock to talk to Emeritus.
I'm sorry, if we could turn the microphones off, please. So the thing is that if you were to do that, it could be just easily disposed into the spam or junk mail folder. there needs to be a conveyance by a peer that this is a legitimate concern. It's been reviewed at the trio level, and that it is being communicated as you've got a serious professionalism concern that's been cited by this person, and you need to, in some way, be able to reflect and respond meaningfully to it. Now, we will talk to them about, well, how can you process this? Or what are my next steps in terms of becoming that better person? But it's not meant to become a, an argument over I never did this or I never do this or I was having a bad day or I just got served papers for my divorce or whatever. Whatever the excuses or reasoning that is put forward, that's not the job of the peer messenger. It's only to communicate dispassionately what the professionalism concern is and the responsibility for the recipient to then act upon it to become better at what they're doing. Because the problem is there are some people who won't go ahead and realize that they're doing wrong. Like the young man here on the sidewalk selling moral compasses. A, they don't exist. B, he's selling one for $10 and two for 25 bucks. So we have all kinds of people out there in the world, and many of them maybe in medicine, who may not realize, and no one's ever told them before, that there is perhaps something in which they need to consider how they can go ahead and become a better clinician and a better servant of the patient's needs.
Thank you. Dr. Clark, you had a question?
Great, and there is also a question in the chat, so I hope we can get to that too. It seems good. I wanted to follow up a little bit on this idea of the cup of coffee also, but expanding it, is this something you've seen implemented for our trainees, for example? Or how do
Yeah.
you think then, for students, all these levels, we have lots of students, residents, fellows, and then the other is the sort of whole healthcare team, right? Often we're interacting with nurses, techs,
Right.
other support staff, other professionals, but, sort of the other team members, for the, what's become a multidisciplinary team sport.
Right.
Thank
So
you.
actually, if you go to the Tulane Professionalism program, you can see there is an entire algorithm of how concerns are processed and certain specific ones, for instance, things having to do with Clery violations or sexual aggression, that sort of thing, they go to a Clery office. If it is something that having to do with professionalism of a medical student, that will go to the senior associate dean for student affairs. If it is having to do with a resident, it will go to the core clinical competency committee. And so each person has their own turf. So when we're doing the peer messenger program at Tulane, it really is concentrating on just the faculty. And we do have one area where it's always we are trying to be politically sensitive in that we have some faculty who are more over at the VA. And so fortunately, I used to work at the VA until the end of December. And so I had a working relationship with the chief of staff, and I would be the person in the trio to say, this needs to go to the chief of staff over at the VA, rather than just going through as a peer messenger issue because the VA needed to be alerted that there was something serious going on here. And so it's all about, it is in essence, how do we stay in our lane? Because there are a lot of specifically constructed responses two professionalism lapses that have been put in place over the years. And what we try to do is respect those lanes. And so I would seriously, if you just put in Tulane professionalism program, it'll take you straight to it. And one of the tabs will show you the algorithm of how do we handle and respond to a professionalism concern.
Thank
And
you very
you
much.
said there was something in the chat.
Yeah, so we have a Leanne. I don't know if you want to, Leanne, if you want to unmute yourself. Here she comes.
Hi. Sorry.
Hello.
So I was wondering if you could explore a little bit more just whether or not kind of our social contract or professional contract with patients has changed, given, you know, the shift in culture, I think, in medicine, focusing on professional wellness and, you know, physicians are oftentimes employees of healthcare systems now and not
Yeah.
direct, you know, employees of, I guess, patients.
Mhm. Well, I've been in medical practice since 1986, got earning my degree in 1983, and needless to say, there have been some ever so subtle shifts in how medicine is practiced. Um, and the corporatization and the managed care aspects of medicine, I believe, have really exacted their toll on primary care and on the longitudinal relationships that we share with patients. And I think we as clinicians and patients as recipients of care have both lost something in that process. That having episodic care makes it a harder thing to promote professionalism when you're seeing people only on a one-time basis. And so, um, I mean, my response is I'm a big believer in continuity of care and that it would be advantageous for the US system to embrace a more primary care basis with specialty care, a hub and spoke type arrangement in the care of patients so that patients will feel that they have a relationship specifically with their doctor and that way they will have that developing longitudinal trust between them and their clinician, and that will promote the virtue within that relationship for both parties.
Thank you.
Wonderful. Well, thank you so much. That takes us to the very top of the hour. It's a fantastic talk. Thank you very much for joining us. May you enjoy your retirement and have a safe move to Cincinnati.
Thank you. And if you ever want me to come back in person, I'll be more than happy to do so. As I was telling Dr. Cohen, I'm flying tomorrow for the closing of our house in Ohio. So thank you so much.
Thank you very much.
Take care. Bye-bye.